Okay, I think we might get started then. It looks like the recording is working. Good afternoon, my name is James Gilkerson. I'm a Professor of Veterinary Microbiology at the Melbourne Veterinary School, and I'm pleased to be chairing this session of the Antimicrobial Awareness Week 2021 program for the National Centre for Antimicrobial Stewardship. So without any further introductions from me, I'm going to hand over to Dr. Laura Hardefeldt, who's a veterinarian who also works at the Melbourne Veterinary School, and she's done some excellent work leading the way in the fight against antimicrobial resistance. So Laura, I'll leave it to you.
Thanks, James, and thanks, Arjun, for organising this seminar series. So today I'm going to kick off talking about a trial that we've been running as a team at the Melbourne Veterinary School with Green Cross Vet Group, looking at three different antimicrobial stewardship programs, really. And we've been doing this now for about the last 3 years. And I'd just like to acknowledge Kirsten Bailey and Susanna Richards in particular, who have been really instrumental in getting this program off the ground with me. And so I'll just kick off and tell you a bit about it. So obviously, I'm probably preaching to the converted here, but antimicrobial resistance is becoming a bigger problem for veterinarians. And this is just a bit of a heat map of the instances of MRSP in Australia from Kate Worthing's work in 2018, and the size of the dot correlates with the number of isolates. And so you can see that particularly in Melbourne, Sydney and Brisbane, that there's been this emergence of MRSP in companion animal practice. And so, just as some background, why do we need antimicrobial stewardship? And I think, well, there is antimicrobial resistance in animals, and it's causing problems for veterinarians in clinical practice. And I think for companion animal practice, MRSP is certainly the biggest one, but we are seeing more ESBLs in enteric gram-negatives, and particularly more disease associated with enterococci. And is it getting worse? That's a really difficult question to answer. Certainly we're seeing it more. Is that because we're looking more? It's hard to know. But what we do know is that changing antimicrobial use is unlikely to affect our patient outcomes. And importantly, resistance is unlikely to develop in the absence of antimicrobial therapy, at least in pathogens. And we know that the contribution of antibiotic use in animals to antimicrobial resistance is greater than zero. How much greater than zero? It's really hard to quantify that, but we know that we are having a contribution of some degree. So this is what we did in the trial, and what we were really interested in is whether implementing a more intensive antimicrobial stewardship program would have a better impact than just doing kind of an educational program alone. And so we were lucky enough to work with Green Cross vets, and we had 3 arms of this trial. We had the control arm, which did have some interventions. They got the prescribing guideline poster, which I'm going to show you in a minute, and they got the webinar series. We had the kind of minimal intervention arm, which had a stewardship champion appointed. They had the traffic light system. I'll go through some of these interventions independently in a minute. They had some diagnostic testing guidelines, and they made sure that all their staff knew about the policies. And then we had the intensive arm, which did all of the above, but also developed their own local prescribing guidelines, restricted critically important antimicrobials, did some audit and feedback, and also implemented delayed prescribing. So we analysed the trial in 3 ways. We did a survey, which about half of the vets participating in the trial completed. I looked at the big data behind this trial, so the antibiotic use in the 2 years before the trial compared to the implementation phase, which was from when we started the webinar series and sent out all of the information till the end of the webinar series. So that was at about an 8-month period. And then the post-implementation period after that, which we looked at around about a 12-month period after the implementation phase. And then we also did some qualitative analysis. So a series of interviews, not just with vets, but also with nurses and practice managers and the regional clinical directors. And that data is still being analysed. So I'm not going to talk about that today, but that will come. So in terms of the survey results, we had around 270 vets who completed the survey from 108 clinics. There was 135 clinics that participated. So we almost got survey responses from every practice. And 2 out of 3 vets thought that they had an AMS program. So, which was we were pretty happy with that. 83% of the vets with an AMS program used the guidelines, and this is the guideline poster that we sent out to them, which we developed with Agriculture Victoria, and so it's just syndromic antimicrobial recommendations on this poster. This is the webinars that we put on, so it was included some international and national experts, and again it was syndromic, so antimicrobial therapy for dental disease and perioperative and that sort of thing. About half the vets watched them. Those who watched them thought they were really useful. About 91% thought they were useful. So if we could get people to watch them, that was really effective. So the Stewardship Champion, about 70% of the Stewardship Champions were vets, and almost half of them were the veterinary director or the lead veterinarian at each practice. And just under half of the practices had a Stewardship Champion, and 86% of those people who had one agreed that the Stewardship Champion was an effective advocate for the use of appropriate use of antibiotics. So it was an effective intervention for those who put it in, or they felt it was. This is the traffic light system. It's based off the Australian Scientific and Technical Advisory Group on AMR's ratings, and this poster is freely downloadable from our website or the Agriculture Victoria website, and it's got the most common antimicrobials used in companion animal practice and where they sit in terms of their importance to human medicine. So only around a third of the vets implemented this traffic light system, but 71% of them who did implement it thought it changed their prescribing approach. So again, a pretty effective intervention from the vet's perspective. Audit and feedback was another one. So this was just in the intensive arm of the study. So only about a third of the practices implemented it and were asked to implement it. Only about half of those did. But again, 90% of those who implemented it thought it was a useful intervention. So these are, I think, really good results, because now we can go back to the vets that didn't implement it and try and help them to do that, given that we know that it was a pretty useful thing to do. And then finally, the delayed prescribing had actually a really wide uptake. We had a webinar at the end of the implementation phase on delayed prescribing. So in fact, everybody heard about it, but only the most intensive arm of the study were asked to implement it. But in fact, nearly 60% of vets used delayed prescribing, and again, 90% thought it was a useful way of reducing unnecessary antimicrobial use. So, and this is the little poster that we developed to help vets to use delayed prescribing. So, in summary, in the dark bars, how many people use the intervention, and in the grey bar is how many people thought it improved their prescribing approach. And so we can see that, even though some of these things like audit and feedback had a low uptake, they had a really big impact in that group, and I think they're the ones that we need to work on. They probably had a low uptake because they're a little more challenging to implement, and so that's something that we can work on in the next iteration of this trial, trying to help make these more user-friendly interventions. But some of the ones that are easy to do, like delayed prescribing, the educational webinars, and particularly the traffic light, system all had a really impressive impact, I think, for those people who use them. So moving on to what we saw in the antibiotic use analysis. So we had this pre-trial period. There was 135 practices, and we looked at the antibiotic use in the 2 years preceding the trial. And the overall incidence rate of prescribing was 3.7 per 100 consults. So that means that around about four of every 100 consultations, there was an antimicrobial prescribed. It was already decreasing. So we saw a 13% decrease between those two 12-month periods before the trial began. And there was a really quite variable between clinics, ranging from 1.3 to 8.9 per 100 consultations, but the median was 3.4, and in fact nearly 90% of the clinics prescribed less than 5 per 100 consultations. So during the trial, there was about 8.5 million consultations and about 250,000 systemic antimicrobial treatments dispensed. And 8 antimicrobials accounted for almost 95% of all antimicrobials dispensed. And this is not a shock. This has, been consistent with previous work that we've done, plus previous work that's been done overseas. So amoxicillin, clavulanate, cephalexin, and metronidazole were by far and away, accounted for most, and then cefavecin, and then doxycycline, enrofloxacin, cefazolin and amoxicillin, but getting down to pretty low numbers once we get to those last ones on the list. During the trial, the incidence rate of prescribing in the implementation period was 2.4 per 100 consultations. So remembering we started at 3.7, and then in the post-implementation phase, it reduced further to 1.9. So we had a decrease of 47% from the start of the pre-trial period to the end of the post-implementation period. And we saw that prescribing in the clinics enrolled in the most intensive in AMS2 was 11% and 14% lower than in the control groups in the implementation and post-implementation periods, respectively. So we did see a bigger effect with the more intensive interventions. Incidentally, the COVID-19 pandemic, we saw an increase by 7% in antimicrobial prescribing. So just importantly, the rates of all antimicrobial groups decreased in all intervention groups. So in all of them, in the low importance, medium importance, and high importance rated antimicrobials, they all went down in all of the intervention arms. But the proportion of antimicrobials did bump around a bit, and it's kind of interesting. So if we look at low importance antimicrobials, then use increased, which was really encouraging. I think we were able to get people to use these drugs more. So it increased from around 12% to around 20%. Medium importance rated antimicrobials decreased from 74% to around 52%. But somewhat complexingly, the high importance rated antimicrobial use increased, the proportion increased from around 12 to 20% in the control group, and not so much in the intervention arms, but it still did increase a little from 12 to 16% in the intermediate group and 15 to 16% in the most intensive group in AMS2. So it was, I think it's really interesting that we weren't able to shift that high importance rated antimicrobial use, and let's face it, that's primarily convenia, and there's some really ingrained reasons that vets are using convenia, and I think it needs to be tackled quite specifically. We also looked at the high prescribing practices. So these were the practices that were in the top 25% of the prescribers in the 2 years prior to the trial. And in all arms of the study, they reduced their antimicrobial use the most. And so we can see that in pre-trial and during the trial, this is the difference for the high prescribing practices in the control in AMS1 and in AMS2 compared to all other practices, and that was significant in every group. And if we think about why that might be, there's probably a lot more low-hanging fruit in those high prescribing practices that's easy to pick off. But also I think there's probably a degree of the upper management in Green Cross identifying those practices and putting a bit more effort into implementing the trial there as well. So hopefully some of that will come out in the qualitative evaluation. So in summary, 58% of the vets thought they had changed their prescribing practices in the survey, and we saw a 47% decrease in the incidence rate of antimicrobial prescribing over the trial period. So I want to thank the whole team at Green Cross, especially the veterinary directors, particularly Tracy Fisher, who was instrumental in data acquisition, and Jess Irado and Lindsay Evans, who really led this intervention. Also Mags Awad and Rachel Che, who was there right at the beginning as well. And I need to acknowledge Vet Compass Australia and the LEAF grant that they're funded with, because we couldn't have done this project without that data. And I'd be happy to answer any questions.
Thanks, Laura. I haven't got any questions in the chat, but if anyone who's online had a question, if they wanted to raise their hand or just pop their camera on and unmute, I'm sure we can cope with that too. Just while we're waiting.
If we have any, if the participants have any questions, they can type it in and then I can unmute them.
Okay.
Because they won't be able to unmute themselves yet. So you're just in the Q&A box or in the chat box, whatever you prefer.
Thanks, Arjun. Just while we're waiting for people to do some typing, because if they're like me, they can type slowly. Laura, with the antimicrobial stewardship champions, I think that was it's sort of an easy strategy to implement in some ways. Do you think the results would have been slightly different or different at all if we had more practice managers or nurses as the stewardship champion rather than veterinarians? I'd be interested in your thoughts.
Yeah, I actually don't think, I think that the role of practice managers and nurses is probably undervalued in antimicrobial stewardship in vet practices. They play a really important role in human hospitals, and I think that they probably would be as effective as a veterinarian, and possibly have more time or be allowed to have more dedicated time for that role. And so there was some practice managers or nurses who did play the champion in this trial, and I know that Susanna has interviewed some of those. So it'll be really interesting to find out how they thought the program went and maybe look at some of the data in those practices specifically. But I do think that moving forward, especially in practices where there's a high staff turnover, having somebody who has a leadership role in the practice, whether they're a vet or a vet nurse or a practice manager, but somebody who's there and knows what's going on is probably more important than having a veterinarian themselves. So
excellent. So it doesn't look like we've got any more questions in the Q&A. Did you want to take this opportunity then to talk a little bit more around the perplexing nature of the high-rated antimicrobials going up and what you think might be behind that? And also, I think just thinking about the results of the trial, where veterinary practice might go in order to, some of the things we might be able to do to address this and raise people's awareness.
Yeah, I'm going to take the second part of that first, because that's an easy one.
Cool.
So the plan now with this trial is to now have a consolidated program that is implemented in all the practices moving forward. And I think it was really valuable to have the three levels of the program. What I didn't say is that this wasn't a randomized control trial. We did place specific practices into specific arms of the trial based on their capacity to implement the intervention. And I think that's really important because, you know, we know that some practices it's really important in this space to bring people with you and not to impose these interventions onto practitioners. And so I think now that, you know, we've had nearly 3 years of this trial where everybody's been doing something, we'll be able to, and there are some parts of the intervention, some interventions that didn't have a great uptake or didn't have a great impact that we're going to leave out of the consolidated program, and we're just going to implement one program across all the practices. And so I think that'll be really interesting to see, especially in the practices that were in the control arm, how they go stepping up into the more intensive program as we move forward. So that's the plan, and so we'll have some more data in 2 or 3 years' time as to, you know, if we were able to maintain the prescribing rates where we are. It's unlikely that we'll be able to maintain the reduction in antimicrobial use, and nor do we want to. At some point, we're at appropriate use, right? And we don't want to reduce use to a point where it impacts on animal welfare. And so, but you know, maybe we'll be looking more at those high importance rated antimicrobials and what we can do to try and curb that use, which is probably a good segue into what we can do to curb that use. And, you know, it's really challenging. And I think not only do vets, you know, lean on these drugs because of the convenience, but clients do as well, and they're used to having them now. And so there's that pressure to prescribe them. And I think Ree's probably got some insights here and can, you know, add some really valuable insights. But I think it will require, there's some evidence from the UK that if we have an intervention that targets that specifically, that we can reduce the use of those high importance rated drugs, or, you know, reduce the use of convenia. But I think it really is going to take quite a big effort. And in this trial, I mean, we didn't see an increase in the use of those drugs. We just saw a decrease in the use of everything else. And so the proportionate use increased for those. So, but certainly people seem to not be able to give up on, you know, give them up just yet.
Cool. If there, Arjun, can you see any questions in the Q&A? I can't from where I am, but
Nope, none that I have here.
Have you got any insights, Ree?
Well, I was just going to say it's a great introduction into what I would like to talk about what vet micro labs can do to contribute to things like reducing convenia use. And I think what we have all learned, and what our colleagues in the medical field have also learned, is that this is never going to be a single thing that solves the problem. It's going to be lots of little things that all come together and build a bit of momentum, and then it becomes normal practice to perhaps not use convenia with every fractious cat that needs antibiotics. Or
not so fractious cat.
Or even, yeah.
So I think we've probably come up to our time limit. So in order to keep on the program, Laura, thank you very much for that. That sounds like a lot of work that you and Kirsten and the team have put in to get this to this stage, and I look forward to seeing some more of the results in years to come. And
thanks, James.
We'll jump over to Ree with that very nice segue. Great pass from Laura, good pick up from Ree. And so Ree Scarborough is a veterinarian. She's again working in the APCAH lab as part of the National Centre for Antimicrobial Stewardship, and she's doing her PhD currently, busily working away, getting everything finished, and she's going to talk to us this afternoon about how veterinary laboratories can contribute to antimicrobial stewardship. So, thanks, Ree.
Thank you, James. So, yes, sorry, I shouldn't have skipped over that. So I'm doing my PhD with NCAS and the University of Melbourne and APCAH. I can't say, I think James said that I work in the lab, and I want to say I don't actually get into the lab, but today I am going to talk about what commercial veterinary microbiology laboratories might be able to do to support our efforts to promote better antimicrobial use in vet practices. And spoiler alert, the message that I'm giving you today is that what happens here in the micro lab can change what happens here at the animals side. And that can happen in two main ways that I've thought of, at least, that other people might have more ideas, but changing the individual animal culture and susceptibility reports is one way that labs can help. And another way is to use pooled data from all the animals who are submitting samples to one lab, and also multiple labs using their data together. That's the dream, to produce cumulative antibiograms and perhaps some other analyses that we can use to advise on empirical treatment of conditions in vet science. So before I get into it, I thought I should just say, for clarity, that veterinary microbiology is not exactly the same as human microbiology. Of course, there is a huge overlap in the microbes that are important in human health and animal health, but there are some that are individual, that are specific to one or the other. And a horse is not the same as the human. They do actually have some major differences. So, and for anyone in the audience, and I think most people who are here today at least have probably had the pleasure of doing these kinds of things in a lab, where you put a sample from an animal onto a plate of sheep blood agar, and then you select some colonies and you plate it up on a disc, an agar plate with discs of antimicrobials, and the result of that tells you, the zone of inhibition around those discs tells you whether a bug is resistant or susceptible to that antibiotic. I would say up front, for anyone who's from the medical field and doesn't know, we actually have a bit of a challenge in the veterinary space in that we have a lack of species and site-specific breakpoints. It's starting to change, but it's slow. And so, for example, I'm going to talk a bit about dog and cat urine later, and we don't actually have, for the CDS method here, we don't actually have dog-specific, urine-specific breakpoints to say, for amoxicillin to say whether it's resistant or susceptible. And so what gets used is the tissue breakpoint. So that may not be the best reflection of how the antibiotic actually performs in real life. But those are the cards we've been dealt, and that's what we've got. Another note is that there are various providers of culture and susceptibility testing in Australia. The universities that have vet schools especially are doing this kind of stuff. There are some government laboratories doing it, some smaller private providers, and one of them I'll speak about later is ASAP Laboratory in Victoria. There are some large providers like IDEX that are national, and then some vets are also using human microbiology services, mainly due to reasons of access. And so you can imagine, after what I've just said about the differences, there are some challenges in that as well. The other thing to know is who pays. We don't have Medicare for pets, so the lab bills the vet clinic, who bills the animal owner, and this can be, for a culture and susceptibility test in a small animal, this might be something in the region of $200 out of pocket for the animal owner, maybe a bit offset by insurance if the owner has insurance, but that's less than 20% in Australia have insurance. So the high cost leads to a reluctance to do the culture and susceptibility tests in the first place. So there is a lot of empirical treatment going on, which speaks to the imperative to have good data, antibiogram data, to guide that kind of empirical therapy that vets are doing almost all the time. So thinking about the individual animal culture and susceptibility reports, here is like a traditional report from a dog, some Staph aureus, and you can see a very long list of antibiotics that were tested by the laboratory, and an R for resistant, S for susceptible. Results are provided regardless of whether the growth was considered clinically significant. All the antimicrobials tested are listed, including the highest priority critically important antimicrobials, the red ones that Laura was talking about earlier. The drugs are listed in alphabetical or sometimes a random order like this. And there's no guidance provided on what would be a good treatment choice and what would be a less good treatment choice. As a result of that, a clinician receiving this report might start to prioritise other factors other than antimicrobial resistance risk, such as, is this drug on the shelf in the clinic? How familiar am I with it? How easy is it to give to this animal? what's the cost, and maybe even what the client preferences are. But we started to think, well, what could you do to add some guidance simply to this report? Well, if I overlay the colours of the antimicrobial importance ratings for these drugs, you can see of all the susceptible drugs, the green ones light up. There are 4 good choices there that could be used before the orange ones come in, and definitely before the red ones come in. But that's not something that had been done in the past. In 2019, I note that the Royal College of Pathologists for the medical culture and susceptibility testing said that there should be some new rules about how things are reported. There should be no susceptibility results given to the clinician if the isolates are not clinically significant, that they should report narrow spectrum agents, and they should selectively report, not give results for fluoroquinolones, for example, if there are lower importance agents to which the bug is susceptible. So all of this is designed to help guide the clinician to making better choices. And at the University of Melbourne Veterinary Laboratory out at Werribee decided to do something similar, and so they put the antibiotics in blocks according to their importance ratings, and I believe have also, and Mark can confirm this later, not reported all the results all of the time. So they're grouped and colour-coded, and there's a bit of an explanation in each of those coloured bars you can see of how to interpret that, how to use those importance ratings to guide your prescribing. Our colleagues at the University of Sydney also have an AMS program, and as part of that they decided to follow suit and do something similar to their reports. It looks a bit different, the effect is the same. Really clear guidance as to which ones are preferred choices, and a little bit of an explanation about why we are bothering to talk about antimicrobial importance there. ASAP Laboratory wanted to do something similar for in their private business. Unfortunately, due to some operational issues that were compounded by COVID, it wasn't possible to replicate what the university labs had done, but they did manage to add these notes to the bottom of their reports, which ask vets at least to consider the APCAH ratings of those antimicrobials to which the bug is susceptible, and also to think about using the Australian Veterinary Prescribing guidelines that have been developed by Laura and others in our team. And so that is, although it wasn't what we had hoped to achieve, it was still a really important step forward and something that's quite handy for vets. So the question is, will other vet microbiology services follow with similar changes to the way that they report? Well, we can only guess, but it is, I would say, if anyone's out there who runs a vet micro lab, it's a low-cost intervention with potentially really high impact. Vets who only occasionally order a culture and susceptibility test will see those reports and can't avoid learning about the antimicrobial importance ratings, and that's such an important message to get out there that I think is vets generally, the ones I've spoken to, that they haven't, a lot of them haven't heard of the ratings yet. Qualitative research that I've done speaking to vets would suggest that they actually would really like to get this kind of extra guidance on their culture and susceptibility reports, anything to make their decision making easier when they're busy in the clinic. I don't have data to support that yet, since these changes are being made in various labs, but I'm planning to collect some. The experience with the change of reporting in human medicine suggests that some clinicians might be a little bit unimpressed at first about having selective reporting, not seeing all the results that the lab has actually got, but anecdotally at least, most of them become accustomed to this new system quite quickly. So it would also be great to have pooled data, cumulative antibiograms, and maybe there's an argument for doing some, population level simulations of using antibiotics. So the dream, I guess, is that labs would regularly aggregate their data and provide it to clients, and it would be local and it would be recent, and there would be sufficiently large numbers of isolates so that we could draw conclusions. And all of this might go into a central database that could give us national trends, perhaps, in antimicrobial resistance in animal pathogens. it is a bit of a pipe dream. The reality is quite far from that at the moment. Request forms are often quite poorly filled out by vets. Labs say sometimes you don't even get the species, let alone which part of the body it came from, let alone any relevant clinical history. So a bit tricky to get good data out when you don't actually know what you're looking at. Labs also use different ways of IDing the bugs and different methods of testing susceptibility. There's also probably a lack of incentives and resources in the sector to do this work, but we can dream. So as a sort of one-off example of what could be done, I looked at some data from dog and cat urine. That's a good one to study because it's always obvious which body site the sample came from. So I was very fortunate to get some data from ASAP laboratory, 5 years of all of the dog and cat urine samples, of which there were more than 5,500 culture positive ones from thousands of different animals. And they use this method of the antimicrobial discs. The identification of the bugs I won't go through, but all the usual suspects were there, nothing too surprising. And this is what the cumulative antibiogram looks like. I've grouped the antimicrobials across the top according to their importance ratings. And I don't want you to look at all the numbers and get bamboozled. Just take an overall impression that green is a good result. That's very high susceptibility to that antibiotic. And this is even despite the fact that the dogs and cats that actually got samples sent in for these kinds of tests were already likely to be, because of the cost reasons, they're already likely to be dogs and cats that had already received antimicrobials empirically and that the treatment had failed or they were somehow complex cases. Those tend to be the ones that end up getting a culture susceptibility result at all. So they are likely to have slightly more resistance than the general population of sort of first presentation pathogens that a vet might see in general practice. But despite that, these are really encouraging results. But I think, you know, this is a sort of precious thing that we have good susceptibility, and we really need to look after that. In cats, you can see a few more grey cells where we couldn't make much determination because there were fewer samples. There are fewer cats as pets in Australia, and there were fewer and they get fewer UTIs. So as a result, there were fewer samples to talk about. But still, where there were colours, there is a lot of green, and that's a great result. Those antibiograms are well and good for those people who are really into it, but I think clinicians don't really want to read through that, and I think we do have to find a way to summarise that for an easy digestion, if you like. But I think we need to be careful about how we summarise it. One way I could have summarised my data is to say the most effective antibiotic against all of the urinary pathogens was amoxicillin clavulanate, and we know vets already love amoxiclav, so that's probably not a great message because it's a medium importance and very broad spectrum, and it's most resistance to cephalexin. But here's another way I could present the same things in summary: that 94% were susceptible to a low importance antibiotic, only 4% required in medium importance antibiotics such as amoxiclav, and 1% were resistant to all low and medium importance agents tested, of which 2/3 could be treated with enrofloxacin. But none of those bugs that couldn't be treated with low and medium could be treated with cefepime. So there was no microbiological justification, I should say, for using cefepime in these cases. So this is a bit of a thought, an idea to put forward to people about how we might look at analysing the antibiogram data, that if we could get antibiogram data all the time, that takes into consideration the fact that there might be multiple bugs in a single sample, and that different antibiotics have different risks. So the way that I approached this was to pretend to apply a same antibiotic as a first-line antibiotic to all of the dogs in that population that I was looking at, and to see what bugs survived and then what I would need to treat them with as a second line in order to get a cure. And then I could incorporate this kind of, if you like, an antimicrobial resistance risk score, using the importance ratings of the drugs that I needed to use and the number of times I needed to apply it in order to achieve those, I guess, theoretical cures. And so this gives a really clear winning pathway. You can see the ones with the bold outline. The first choice antibiotic would be TMS, curing 87% of cases, possibly more in vivo. And then for anything left, you could treat with amoxicillin with a score, overall score for that pathway, that cost of antimicrobial use of 1.18, which is a lot better than some of the scores you can see down below with some of those popular drugs, like using amoxiclav first, followed by cefalexin 2.67. So that's another way of thinking about how do we summarize and say, well, what is the best choice here? The beautiful thing about this result is that it lines up perfectly with the international and Australian guidelines for UTIs in dogs and cats. It doesn't, however, line up with what vets are actually treating UTIs with. Really, we love using amoxiclav in dog UTIs and cefalexin, and probably like neither of those should be in the top two. I did the same thing for cats, same or similar results. And unfortunately in cats, because of the difficulties / unwillingness to medicate orally, there's a really high use of cefavecin and some amoxiclav as well. So that's not ideal. My take-home messages for any vets in the audience, and I think I looked at the list and recognised a few names. The Australian Vet Prescribing Guidelines saying use amoxicillin or TMS are absolutely spot on and supported by our results. Dog and cat UTIs almost never actually need amoxiclav, let alone enrofloxacin, and UTIs never need cefavecin. For fractious cats, people could consider using a long-acting amoxicillin injection at 48-hour intervals. That's something that could work for those cats that just really aren't going to let you put a tablet down their throat twice a day. And I guess as a parting thought, imagine what we could learn and what we could do if we could automate all of those analyses that I did for that one lab's one kind of condition. If we could replicate that and have that all the time, I think that we could be in a much better position, and hopefully that time is coming. Thank you very much to NCAS for my scholarship, to the Australian Government, ASAP Laboratory, who've been so helpful, make data useful, and to my supervisory team. Oh, that's it.
Thanks, Sri. That's really interesting. And we've got a minute for some further questions.
Oh.
If anyone online has any questions, pop them into the Q&A. And in the absence of that, while we're waiting, I guess I'm just wondering, Ree, not that you've got any data, but what your thoughts might be around how this might change from a veterinary point of view, if rather than the pathologists signing off on the culture and susceptibility testing reports, if there was a veterinary microbiologist involved that said this was or wasn't a significant organism, and whether that might make a difference. Not that, as a veterinary microbiologist, not that I've got a conflict of interest, but, just saying.
I don't have a choice how to answer that, but no, I do honestly, present company aside, I do think that a veterinary microbiologist would add a lot of value in these scenarios. But I think the problem is, and correct me if I'm wrong, but I don't think we have enough veterinary microbiologists to go around.
I don't think you can ever have enough veterinary microbiologists, can you, Ree? Anyway, that's just my biased opinion. Yeah. We don't have any more questions in the Q&A, but conveniently, we are at time for the next talk, which is you.
Well, okay, let me find give me a second to switch over to the next one.
So while you're putting that up, I just remind our participants that if they do have any questions, whether it's about this, Laura's still on the line. If you've got any questions that, Ree's talk has prompted you to ask a question of Laura, you can still pop that in the Q&A. we can certainly accommodate that sort of discussion. But also, if Ree's next talk prompts some more questions about Ree's first talk, I'm sure she'd be more than happy to answer any questions you've got.
Now, something's weird is happening with my own screen, but are you guys seeing my presentation?
No, we're just seeing black screen.
Cool.
Great.
Let me try again. Did something happen there?
That's better.
All right. So this talk is really kind of geared towards vets who are in clinical practice, but perhaps it could be applied to other clinicians who prescribe antibiotics. I thought at Know Your Audience, these are evidence-based ways to talk to pet owners about responsible antimicrobial use. And this is the result of a study that I've done, which had two main parts: a pet owner survey, which I was only going to use as a screening and recruitment tool for some pet owner interviews. But then I thought, well, if I'm going to survey people, I might as well find out more about them, and I'll analyse that too. So to my knowledge, this was the first survey of Australian pet owners specifically about antibiotics for pets. I ran it earlier this year, promoted it through social media channels, through some friends' vet clinics, through some personal networks. Got quite a few responses. I could analyse 558 of them, and the others were not complete enough to analyse. And the survey covered the expectations of veterinary consultation, expectations of antibiotics specifically, the knowledge that people had about antibiotics, antibiotic resistance, that kind of thing, opinions about antibiotic use. And I put this in pink because I think this is the first time it's been asked globally, what were the communication preferences of the pet owners when vets were declining to give antibiotics to a sick pet, or delaying giving antibiotics, or trying to persuade an owner to give a course of antibiotic tablets to their pet rather than the convenient long-acting injection, which we don't need to go over again. You know it's there and you know it's a problem. The survey was about 10 minutes for the participants. And to give you an idea of what I asked, these are some of the communication questions that I asked. Which statements from your vet would make you feel most comfortable with a decision not to give antibiotics? So there's a question about, there's a response about vet's experience, some clinical trials, the pet's immune system. And then I had this question about which of these things would most likely convince you to use antibiotic tablets versus a long-acting injection. So I suggested the lower risk of antibiotic-resistant bacteria, price, side effects, etc., ending up with public health and guidelines. And this has been published recently, hot off the press, in Antibiotics, and that's open access for anyone who wants to look that up. But I'll just present the key findings that vets could use to inform their communication with pet owners. And I would quickly note that my demographics of my participants were not exactly representative of the Australian population. It was about 97% female, a lot of postgraduate educated people, and a lot of people in the highest socioeconomic quintile. But nevertheless, this is what I found in that group. The pet owners commonly expected some medication from a consultation, but they were rarely actually upset if antibiotics were not given. 97% thought that vets should only give antibiotics when they're really needed. 72% acknowledged AMR as a serious problem in Australia. More than half understood that antibiotics carry significant risks, but only half thought that the risks could extend to animals outside the treated animal, to humans in the household, or to the environment, or to animals and humans outside the household. So there was a sort of limited understanding of what the risks of antibiotics were. Interestingly, despite the fact that I had so many responses from people from a health background, only 39% thought that bacteria would transfer from pets to owners. And weirdly enough, fewer people thought that bacteria would transfer to from owners to pets. So I'm not sure why there's that discrepancy, but perhaps it's due to more focused on the zoonotic potential. I would say that, looking at some of Laura's work about the exposure of people in Australia to antibiotics versus animals per life year, we know that actually the exposure in the human owners is likely to be about twice that of their pets. So if anyone is putting anyone at risk with AMR, perhaps it's more the owners than the pets. Speaking about communication preferences, when a vet is declining to give antibiotics to a sick animal, the owners want to hear what the reassuring clinical signs are. They want to hear any supporting empirical data, which I know is not always available, but where it is, it's good to talk about it. And lots of people also wanted to hear about the vet's personal experience with this condition, seeing it get better without antibiotics. When considering the more difficult tableting option versus the long-acting injection, owners cared most about the direct adverse effects for their pet, and the AMR risk to their pet was a close second. They weren't so interested in public health consequences of using a third-generation cephalosporin or following the veterinary prescribing guidelines. So when you're presenting it to an owner, perhaps just stick to the what are the effects in that particular pet. The owners placed a higher priority on treatment effectiveness than on convenience or cost. 96% of owners said they trusted their vet to do the right thing by their animal, and I think that's a really nice thing for people to remember. So I then rolled into some pet owner interviews. I specifically chose people from their survey responses to approach, depending on what they said. So I wanted a range of people who knew a lot about antibiotics, and then some people who didn't know very much at all about antibiotics. And people who lived in different areas and said that there was different age groups. I interviewed everyone for about 60 minutes on Zoom. You can see me talking there. Why am I always waving my hands? I don't know. Anyway, the interview themes were quite wide-ranging. There was a little bit of covering what was already covered in the survey, but in more detail, what they understood about bacteria and antibiotics and resistance, what they expected from their vet in their consultation, what would convince them to undertake a less convenient treatment, what would make them feel better about walking out of a consultation without any medication, and what are, just generally their experiences with vets and antibiotics. And some people offered up also their contrasting or similar experiences with human practitioners and antibiotics. So some things that came through quite strongly was owners saw vets as a trusted expert who had their animal's best interest at heart. So I trust the vets, what they give me, that it's good for my dogs, that it's supposed to have it. I'm not sure about the overuse of antibiotics. My dogs only have antibiotics when the vets say they need it, and I trust them. I have a lot of trust and faith in my vet. Our vet genuinely cares for animals and doesn't want to rush into giving them too many antibiotics over the course of their life, especially too many too quickly. There was a minority of people who expressed some doubt about the motivations of vets sometimes. This person didn't get medication when they had a sick animal, and they said I was probably a little bit pissed off, so my dog didn't get medication because I wanted something to fix it. Doctors say, look, I'll give you a script just in case you need it, but vets tend to say you'll have to come back. So you sort of think, oh God, now I'm going to have to pay for another consultation. Is this a money-making thing? So that's worth being aware of, even though, I actually think that the use of delayed prescribing and giving people the option to have antibiotics without paying for another consultation is quite commonly used. Owners do want to be validated and reassured and talk through the examination findings. For me, it would be the vet saying, this is great that you brought your cat in. Clearly your cat's off their game, there's something going on, and it's good that you brought them down so that we can have a look at them. So for me, the main priority is she really sick, and getting onto it really quickly, because I don't want the cat to die and I don't want it to be from my lack of care. So they really need to be reassured that this is not a life-threatening condition where appropriate. And they had a profound sense of responsibility for the animal's welfare. You want to hear, now I've had a good look at them, I've checked their weight, their temperature, looked down their throat, their eyes, their nose, gone along, and I don't think they need any medication. I think this is something that will resolve. So telling them the reassuring clinical signs. Just For the vets in the audience, I mean, you do this all the time. You take a scruff of, you pick up the scruff of skin at the neck and you look at what happens and you make your observations, but your clients don't necessarily know what you're doing or why. One of the participants said, you know, the vet was always scruffing the animal and letting the skin go and never said anything about it. And then finally they found out that this was to check for hydration, and they said, I don't know what, they should have told me that they were checking for hydration, and that the finding was that the animal was well hydrated, because it would have made me feel better. So it doesn't take much extra time to explain what you're doing and what you're finding. This is another thing we're always doing, looking inside the mouth. And pet owners don't necessarily know what we're doing in there. You might want to tell them, I'm looking for, you know, whether the gums are tacky, whether the gums are pale, whether there's any jaundice, all that sort of thing. It's just important to talk to your clients about what you're doing. And especially if you're finding that things are normal, the clients find that really reassuring. Owners' priorities in the consultation were to relieve their animal's suffering as soon as possible. They might come in believing that antibiotics are the best way to achieve that, but it's possible to talk them around from that position. So they said they don't want to see their pet suffer. If giving an antibiotic would be an easier way to fix something quicker and less stressfully, that's what they want to see. Speed of recovery is a big thing for me. I don't like to see my dog uncomfortable or stressed. Another person said, my doctor hardly ever prescribes antibiotics for me, and she usually just tells me, go away and get over it. And I'm like, I'm healthy, I've got a good immune system, I'll probably overcome this, it'll be fine. Whereas my animal, I'm probably slightly more concerned that they can't have that rational argument. They might be in pain and discomfort, and I want to stop that as quickly as possible, because I can't explain to them that it's better if they just battle it out. So there was this sense that because the animal can't understand what's happening, there was this increased imperative and increased urgency to relieve their discomfort. Pet owners, especially if they're not receiving medication, really want to know what to expect once they go home, and they want a plan to know what to do if things aren't what you expect. So if you're not giving medication, you need to explain that no medication is not going to be the choice of the animal suffering. So then we need to decouple the idea that antibiotics equals relief from suffering in these situations. I tend to be looking for guidance to, as if it gets worse, definitely go to an emergency vet, but I'd be wanting to know what clinical signs to look for. Is this what getting better is supposed to look like? How long should I leave it for? When should I go back? At what point should I be concerned? How much sneezing is too much sneezing? So they really want to know specifically what to do and when to go to an emergency vet or to represent at their GP clinic. Pet owners said they really wanted better instructions on home nursing care than they generally get. They are stressed when they take their sick animal in. So if you can write down the nursing instructions or whatever instructions you've got for them, that really helps, so they can look back on it when their stress levels are down and get the little things that they might have missed during the consultation. Teaching people about medicating their animals is really important. People do sometimes give up, but also have a lot of frustration. You know, they describe having a standoff between them and their dog. They wanted something to go back and refer to if they had trouble doing what they've been asked to do. And they said that video links to YouTube videos or whatever about how to get medications in or how to do certain procedures at home would be really helpful. Telling an owner or just demonstrating to an owner how to give a cat a pill isn't necessarily teaching them how to do it. This pet owner who was new to owning cats said, it looks so easy when they do it. They're obviously highly skilled, but when she went home, she couldn't do it. And she said, what they should have really done is get me to do it in the clinic. Them just showing me was pretty useless. So we need to get better at teaching. If we want to convert people from Convenia to tablets, we really need to be better at teaching pet owners what to do. There were also really big gaps in owners' understanding of antibiotics and antibiotic resistance. So this person said, all I know is that when I've taken them, they work for me. We've had to give them to the dog. They work for him. They make everything better. Someone thought that AMR was essentially, you've got a cold, the GP gives you antibiotics. So when you actually need antibiotics, you already kind of had that, so they don't help your immune system like they should, because your immune system is adjusted for antibiotics. So some sort of idea about recalibrating the immune system. I would assume AMR is the same as, you know, when you get a vaccine, your body builds up a tolerance to whatever you're being injected with. So I assume it would be similar to that. So some sort of idea about immunity or tolerance, which was a little bit off the mark. There was this idea that there was a threshold beyond which antibiotics became risky. So I don't know how much you could take before it becomes too much, but I had the sense that if mum only took 2 courses of antibiotics this year, that's okay. If these kittens only had 1 course of antibiotics this year, I'm okay with that. So that, you know, they felt like there was a threshold. They also felt there was a threshold with duration. So I've had 3 transplants. I know that prolonged use of antibiotics is not a good thing. That's the extent of my understanding. I always got told resistance happens if you don't finish them and if they're overprescribed. I don't know whether a new bacteria forms that the antibiotic doesn't work on, or it just gets stronger and the antibiotic doesn't work. If we don't give the bacteria the whole course, they build up a resistance. So this is this message has been taken on board really strongly by the public, that it's all about finishing the course to avoid antibiotic resistance. And the concept that any exposure to antibiotics can risk resistance is not really out there. But I would acknowledge that vets generally don't have time to explain all of antibiotic resistance and One Health and all of that. So they might not have time to educate pet owners about all of those gaps. It may be more efficient just to bypass some of those misunderstandings and, as I said earlier, focus on the effects, direct effects on their animal of using broad spectrum antibiotics. So using the evidence from that survey and from all those interviews, this is how a vet could decline to give antibiotics and, I think, keep the owner happy. It's great that you brought Fluffy in today to be checked. You know your pet best, and you've observed things are not quite right, and I can understand why this clinical sign would concern you. It tells them that they're a good owner and validates their decision to come in. I'm checking Fluffy all over. I'm pleased to see that she's alert, well hydrated, pulse and breathing normal, etc. What I can find is a mild fever. So you've talked them through everything that you found, including the good news items. Show that you've listened, explain the signs, cite your experience and any data that there is, and reassure them that it's self-limiting. Everything that you've told me and everything I can see today, this is most likely, say, a viral infection. She's got an immune system response. That's why she's got a fever, is not feeling very well. And in my experience, cats generally fight this off in a couple of days and then gradually get back to normal. So the cat will not die from this. They will get better on their own. The best thing we can do for her is relieve her symptoms and give her a whole lot of TLC. I'm going to give her an injection to get her temperature back down, which will make her more comfortable. So addressing those symptoms that the owners are concerned about. Then giving clear and specific home nursing instructions. Take her home, reduce any stresses in her life, give her a quiet, warm place to rest, give her plenty of fresh, cool water, offer regular small meals, maybe heat them up if she's lacking an appetite, because that can help stimulate them. If they really want antibiotics, you could say, I understand, you asked about antibiotics. The good news is she doesn't need them today. They won't help this infection get better any faster. And they could upset her tummy and give her other problems like superbugs. Now, not everyone loves that term, but I can say that pet owners do know what it means. And it's easier than saying antimicrobial resistance. If they press you, you can say, I understand you want her to have antibiotics, but it's my job to advocate for your pet's best interests, which are to avoid antibiotics when they won't help. I could not in good conscience give them to her knowing they won't speed up her recovery and they could do her significant harm. So you're then appealing to their sense that you actually do have their animal's best interests at heart. And then giving them clear expectations of the clinical course that you think will happen, a contingency plan, where to go if things don't go as expected, the triggers for doing that, and be specific and put it in writing if possible. Thank you again to my supervisory team and to the pet owners who were so generous with their time, to NCAS and the scholarship, and Uncle Witolter, who helped me with some of the SPSS stuff that I needed to do.
Thanks, Ray. That was excellent. So once again, if anyone has any questions, if they could pop them in the Q&A there, type them in and we'll get you to unmute your microphone, or get Arjun to help you unmute your microphone. But I guess, Ree, while we're waiting for the Q&A, I'm perplexed, I guess. So here's my question. How widespread do you reckon the finish the course attitude is, and where do you reckon that message comes from?
Well, I don't actually know where it comes from, but it is something that I had heard many times as well. And it's like one of those things you can't pinpoint where you heard it because it's just everywhere. And it never really made complete sense to me, but I guess I couldn't quite argue against it because I didn't know enough while I was, going through these things. But yeah, as to how widespread it is, I would say it is almost a universally held belief that it is failing to finish the course of the antibiotics is why we have antimicrobial resistance. That, and also what's happening in the livestock industry, which people don't really know what's happening, but they think it's really bad. And that they think that that is actually a source of a lot of the problems in humans, in hospital AMR. People often link that with what's happening in the livestock industries, and they often single out one or two of those. I think we all know which ones, and I think that's just a lack of awareness about what's really driving antimicrobial resistance.
I think the irony that Australians have never been more removed from animals, like production animals, in Australian history, and the think that where they think that that's a big issue for them in terms of catching some sort of multi-resistant bacteria is rather amusing. Laura, you've just popped your video on. Have you got a question that you'd like?
Oh, I thought it was an excellent presentation though, Ree. Fantastic. And it's that communication stuff I think is really important for vets, because it's, we can educate people till the cows come home, but it's that innate, I really, that animal is part of the family, right? That's as important as a kid. And so all reason kind of goes out the window. And so that communication, how to communicate with people about not giving antibiotics, I think is just, it's really, really relevant. And it's I think it's one of the more important pieces of research in the AMR space globally in recent years. So yeah, congratulations.
So, Ree, do you think that the difficulties and the attitudes that you were identifying around the revisit, delayed prescribing and coming back for a second injection, all those sort of things, do you think that's about convenience, or do you think that's about cost, or a bit of both, something else?
It's a bit of both, and it does depend a little bit on the owner. There were many owners who said, it actually doesn't, I would do anything for my pets. I don't care if you tell me to come in every single day, twice a day to do something. If that is the best thing for them, I'll do it. But, I guess the people that I interviewed were people who had time to be interviewed. I can't speak for the people that I didn't interview, who may have lots of other demands in their time. I mean, we've all seen if you've been in clinical practice, you've seen and I shouldn't say mum, but it's usually the mum who comes in with a brood of multiple children and multiple animals. And it's like, you've got so much going on. You can't possibly ask this person to be applying an ointment to their dog's eye 4 times a day and expect that to be something that they can just go, oh yeah, that's completely fine. I'll just come home in the middle of my workday and do that before I pick up the kids. Yeah, it's like, yeah, I mean, I get it. It's hard for some people, but there are some people for whom that, that kind of thing, they actually see it as a really important thing that they do, and they're very happy to make that effort. So it's not a one size fits all, but I think those communication things are pretty much one size fits all. People do want all of those things from their vets, that all of that validation, and that, yes, here are all the reassuring things that I've found, and these are the reasons I don't want to give antibiotics, and maybe don't bore them with the One Health public health stuff, because it's just there are too many gaps to fill in if they don't know that, say, bugs transfer between owners and pets. And talking about the consequences for the children in the household of giving the dog antibiotics, it's just maybe a bridge too far. It might just be easy to cut to these are the direct adverse effects that will happen to your pet potentially, and also these are the potential AMR risks to your pet. And that's usually enough for people to go, oh, okay.
Cool. Well, thank you for that, Ree. I think we've come up to the time there. So I think in the interests of keeping to the program so that Arjun doesn't get cross with me, I'll say thank you. And Mark's popped his camera on there. I'll get Mark, if you could pop your, share your slides there and pop them up on the screen. So Mark Miranda runs the clinical microbiology lab at the Melbourne Veterinary School out at Werribee. Amongst a multitude of other things that he does. And he's going to talk to us today about unravelling the spread of antimicrobial and biocide resistances in the veterinary hospital through environmental surveillance. Mark, I might just get you to click on the slideshow.
Yep, I'm trying to.
Trying to?
It's going to the wrong screen. Of course, going to the wrong screen. Display settings, we'll probably swap that. So you should be able to see my full screen now.
Perfect.
All right.
Thank you, Mark. I'll hand over to you.
Okay, all right. So thanks, James. Yes, I was asked to give this talk by Kirsten, and I know that the theme of the day is stewardship, and I'm going to talk about antimicrobial resistance surveillance in the environment, which is a bit different, but I hope at the end I would convince you that essentially these are two sides of the same coin. And because it's a long title, so I thought I would summarize it by saying beware of veterinary surgeons bearing chlorhexidine gluconate, Greeks or not Greeks. All right, so just to give you a bit of context, this is research that we have been doing at the UVet Vet Hospital, which is a teaching hospital where we have our vet students in Werribee. And I'm based in Werribee for clinical microbiology. So we have general practice, we have emergency, ICU, pathology, a number of areas in this hospital. And we have a microbiology lab in which we do all the diagnostic work. So it's, by all accounts, it's a very small lab. We have 1,000 submissions per year from the hospital, so from industrial partners, poultry industry, and consulting veterinarians. Which is, it's a very small operation if you compare that to human labs. We're probably doing in 1 year what a normal lab would do in 2 or 3 weeks. So we process clinical specimens and also environmental samples, and we do identification and AST, but we also help the clinicians in the hospital to manage infection control at the UVet, and also we do passive and active surveillance of infectious risk, and that's what I would like to talk about. So the way we do surveillance of antimicrobial resistance at the UVet, we have essentially 2 lines of inquiry. We do conventional microbiology, so we have regular samples that are taken from the environment of the hospital, different areas. And we cultivate with selective media these swabs, and we look for a number of infectious risks. So we pay particular attention to Salmonella. We also look at coliforms because they are an indicator of fecal contamination, for instance, in phones or keyboards, that sort of things. And we also look at bacteria that carry antibiotic resistance. So we pay attention to MRSAs, VRAs, and also ESBL producers. And we have specific plates that help us to cultivate these organisms and to report them. And we generate these reports. This is just an overview of 10 years of reports, for instance, that essentially we produce about 1 or 2 reports a month for the different parts of the hospital, the command center, the ICU, the clinic, and so on. So that's our routine surveillance. And we have been able to pair this with a more targeted approach using metagenomics. And we had research students, Kanishka Kamatiwata, who spent a bit of time with us. And She went to the hospital, different parts of the hospital, and she swabbed a number of environmental sites. So in particular, she went to the ICU where we had dogs and cats in cages, and she would swab the cages. She would also swab the laundry trolley that were used to collect soil bedding from the cages, and also mop buckets. The reason why I wanted to investigate mop buckets is that normally you should empty a mop bucket after using it, let it dry, and prepare the detergents or disinfectant when you have to mop the spill just before you want to use it. But in practice, often these mop buckets are left full, and God knows what can go into this type of environment. So I wanted to have a look at that. And to do that, we used DNA sequencing system known as nanopore sequencing. If not familiar with this type of system, these are very simple systems. In fact, I have one here. I don't know if you can see it on the camera, but I have one of these little systems here. And you just plug them on a computer, and you can sequence whatever DNA you have in your preparation. And the good thing with nanopore sequencing is that they give you very long reads. So you can have a very long fragment of DNA that potentially can carry antibiotic resistance genes. And also, if you look around this particular gene, you might find also indications that this gene is carried by a particular bacterial pathogen. So you have the identification of the pathogen at the same time of identification of the risk in terms of antibiotic resistance. So that's what we did. And these are some of the results that we collected during this study. So what Kanishka did, she had a look at the ICU cages and the laundry trolley. And the first thing that she found is that she could detect antibiotic resistance genes that confer resistance across pretty much any class of antibiotics in the hospital. So name a class of antibiotic and you will find an antibiotic resistance gene here. And unsurprisingly, these resistance were often associated with particular organisms which we know are resistant or tend to carry resistance, such as Pseudomonas, for instance, or Acinetobacter, but also Staphylococcus and some Enterobacteriaceae. And again, that varies depending on the class of antibiotic that you are considering, but you have this distribution of abundance of ARGs across these different microorganisms. And pretty much the same picture was also found in the laundry trolley. Slightly different picture was given by the mop buckets, and that makes sense in a way because this is a different type of environment, and you can expect different type of microorganisms to grow and thrive in this type of environment, but also carry a range of antibiotic resistant genes. So first thing here, if you look in the environment, you will find plenty of antibiotic resistant genes. The second thing is that if you look at what we call high risk antimicrobial resistance genes, which are genes that confer resistance to either to a pathogenic species of bacterium or genes that are associated with mobile genetic elements such as plasmids or integrons or conjugated transposon, and therefore can jump from one bacterium to another one, we found that there was a nice overlap between some categories of ARGs between the ICU cages, so just the surface of the cages, and the laundry trolley. And that makes sense because this laundry trolley was essentially collecting all the soil bedding from multiple cages housing multiple patients there. So we have a bit of concern because these are the type of antibiotic resistance gene that you don't want to find in your hospital. And there are three other elements of information that we gathered from this study. And the first one is that not only you have a wide range of ARGs conferring resistance to a wide range of antibiotics, but if you look at the waste collection points, such as the laundry, for instance, these ARGs are more abundant in these collecting points compared to the actual cages or actual surface from which they originate. And that's across, again, a range of antibiotic resistance here. And same thing for the mop bucket. So you have more antibiotic resistance genes, so more DNA carrying resistance in the waste collecting point. Not only you have more of these genes, but also tend to congregate together and they co-occur on the same read. So if you look at one antibiotic resistant gene, it was not unusual to find a second one or third one or even more than 4, sitting together side by side on the same piece of DNA. And that was more the case in the laundry trolley than it was in the actual original surface of the ICU cage. That means that all these genes tend to collect together. They sit together in the genome of the bacterium. And not only that, but when they sit together, they tend to be associated with mobile genetic elements. And that is a real problem for me as a microbiologist, because these mobile genetic elements, they can be plasmids, they can be transposons or integrons. They tend to accumulate a number of antibiotic resistant genes, and they tend to be passed from one bacterium to another one. And potentially, they can be passed into nosocomial pathogen or pathogen of importance there. And you have examples, you have 3 long reads that we managed to sequence, and you can see that interspersed with these antibiotic resistant genes that cover a wide range of classes of resistance, you also have all these blue genes and these gray genes which represent the potential of mobilization of the entire block of resistance to another microorganism. And I'm going to give you a couple of examples of this type of events happening in the hospital. So the first example was a strain of Enterobacter that we managed to cultivate from a sink through our routine environmental swabbing. We had a hand washing sink, and our laboratory technical officer, Rhys, was very concerned because he repeatedly isolated a strain of Enterobacter that was carrying an ESBL. So it was resistant to 3rd generation cephalosporins, amongst other things. So we thought we might as well sequence it. And what we found is that this strain of Enterobacter carried a large plasmid. You can see this, the map of this plasmid on the right side of the screen here. This is, we call it the Inc. H12 plasmid. It's just the way we can classify a plasmid. And this large plasmid is conjugative. It can jump from one bacterium to another one. And it also carries two loci that contain aggregation of antibiotic resistance genes. And here you have the different resistance genes that were found on this plasmid. And one that were particularly concerning for us was resistance to cephalosporins and production of ESBLs. We also had resistance to quinolones, we had resistance to colistin. Although this resistance was phenotypically not expressed, it's still a concern to have potential resistance to colistin carried by a plasmid. And not only that, but this plasmid also encoded resistance to a number of heavy metals here, which are listed here. So you have the best of both worlds if you want to have resistance to antibiotics and also to a number of biocide compounds that could be used in some case, for instance, to combat infections. And as I said, it took us 3 rounds of disinfection to get rid of this microorganism and the plasmid that it carried from the ICU. Fortunately, we never saw one of our dogs or cats acquiring an infection and carrying this particular strain of Enterobacter. But still, this is not the type of thing that you want to have in your hospital. And I'm going to talk about this plasmid a bit later, but I just want to talk about another study that we did. We also look at Serastia. So Serastia is a different microorganism that occasionally can infect animals. And I had a look at a collection of isolate that we had over many years from dogs, cats, horses, even birds and rabbits. And I had a look at the phenotypes of these Serastia. And I found that essentially there are 2 groups of strains. There are strains that were not particularly remarkable, and they were susceptible to fluoroquinolones and 3rd generation cephalosporins. But you have in red here, you have these 9 strains that were all consistently resistant to enrofloxacin, and they're also carrying an ESBL. And they all came from different patients, dogs, cats, and horses, different time. And they were often rarely found. So they were very sporadic, but they would occasionally come. And the only commonality that we had with all these strains was they all came after a surgery. So they were all surgical complications. So we did some sequencing, and we did some phylogenetic trees to try to place the genomes of these isolates on a larger phylogenetic tree of the genus Serastia. And the strains that we got from the UVET are all indicated by this this pink square here. And these are just on the left and right. You have two different types of phylogenetic trees, but they tell the same story if you want. So you can have strains that are very similar to each other. You have these three isolates here, but they come from the same cat. So obviously they will be essentially the same genome, and there are almost no difference between them. But these 9 strains that were multi-drug resistant, that came from a variety of animals over a number of years, they were all grouped together on a tree. And there was almost no difference between these 9 strains. It's essentially, it is one clone. It's one strain that has been circulating for many years in a hospital and occasionally causing infections. And not only that, but when you count the number of antibiotic resistance genes present in these strains, and this is represented by these little graph bars here all around this circular representation of the phylogenetic tree, the bigger bar, the more antibiotic resistant genes are carried by the organism. These 9 strains were carrying a high number of antibiotic resistant genes. They were also carrying mutations on the chromosome, which is represented by these 3 triangles here, and these mutations confer resistance to fluoroquinolones. And they're also carrying a number of plasmids, and they are represented by these little dots here. And some of these plasmids were present only in these 9 strains, and they would never been described in any other published sequence of Serastia. So what's going on here? Well, it became a bit clearer when we had a look at sterility testing that we do regularly for chlorhexidine. And it came from one of our clinicians who said, I'm a bit concerned about post-operative complication. Could you check that our process are okay? And they gave us a number of swabs from different parts of the hospital. And they also gave us solutions of chlorhexidine that we're using to disinfect the skin in preparation for surgery. And what we got was Serastia out of these balls of chlorhexidine, which had the same biocode, prefer the same biochemical profile that other Serastia, and was also multi-drug resistant. And when we compare the ability of all collection of isolates to survive in the presence of chlorhexidine, we found that all 9 multi-drug resistant isolates here were also highly resistant to chlorhexidine, and probably they were transmitted to different patients through the chlorhexidine bottles here. So just be very careful when you have disinfectant. Don't assume that your disinfectant is sterile. Even if it's a disinfectant, it can sometimes carry microorganisms that can cause infection. Whereas the other strains were by and large susceptible to chlorhexidine, except this one, which is in orange here, which was also resistant to chlorhexidine. And this particular strain didn't have particularly remarkable resistance for antibiotics, but it was still able to survive in chlorhexidine. And these are just time course experiments showing the ability of these chlorhexidine resistant strains to grow almost immediately after being exposed to chlorhexidine. Okay, so we had a good look at the genomes of all these isolates, and to cut a long story short, what we found is that this group of multi-drug resistant Serastia all contain a plasmid, which is also an INC-H12 plasmid. And if you look at the genes that encode resistance in this plasmid, they are suspiciously similar to the ones that we had also in the isolate from the sink. And in fact, when you align the plasmid from the Serastia and the plasmid from the Enterobacter that we got before in the sink, we found that essentially this is the same plasmid. So 2 different species of bacteria carrying the same plasmid, conferring the same type of antimicrobial resistance in the environment. So how could this happen? Well, you can easily do an experiment, which I did, to demonstrate that you can have a transfer of this type of resistance from one strain to another one. So I used my Enterobacter from the sink, which is killed by chlorhexidine, but contains this multidrug resistance plasmid. And I mix it with my strain of Serastia, which did not have the multidrug resistance plasmid, but was resistant to chlorhexidine. And then I exposed this mix to chlorhexidine, and I plated it with plates containing a third generation cephalosporin. I picked whatever was growing on the plate, and lo and behold, what I had was Serastia, which was now multi-drug resistant at a much higher level compared to the parental strain. And I think that's what happened in the hospital. Essentially, you had this transfer of multiple drug resistance possibly from the Enterobacter or another form of bacteria into the Serastia. Which brings me to my conclusion. So what lesson can we learn from all this? Well, I guess that the main one is that active and passive surveillance of resistance is linked to stewardship of antimicrobials, and you can almost inform your stewardship based on surveillance in the hospital, in the environment. The second thing is that resistance to antimicrobial therapeutic agents and to biocides, disinfectants, are related, and they can have some compounding effect, because now we have a strain of Serastia that is multi-drug resistant and then can also survive and be transmitted by chlorhexidine or by your disinfectant. And you have to get rid of this, and you have limited solutions to do that. The third point is that mobile genetic elements are critical to the dissemination of the resistance in the environment. So you can think of your patients, but also think of the environment as a source of antibiotic resistance, and think of the way to properly monitor antibiotic resistance risks, not only in patients, but also in the environment. And if you have to monitor the antimicrobial resistance risk, well, you may want to think of regular sampling of the environment, having the proper method to analyze these results, and metagenomics is one way to do it. Have an excellent record keeping of your case and also your AST results to be able to work out what's happening, and have a collection of clinical isolates that, or at least ask the microbiologist to keep in collection clinical isolates. You can go back and revisit and try to understand what's going on in the hospital. And that's it for me, and I'm happy to take any questions. I'll probably be out of time, so maybe no questions.
Helps if I turn the mute off, wouldn't it? So thank you for that, Mark. It's as you say, we've come up against the time. I guess one take-home message for veterinarians bearing chlorhexidine in mop buckets. Have you got any tips on how they should manage the risk associated with those sorts of items? Follow simple rules. Empty your mop buckets and let it dry, and let the mop dry. Be aware of the environment as a source of antimicrobial resistance, and don't consider that a disinfectant is sterile. It's not. Well, it should be most of the time, but it can also harbor a number of potential nosocomial organisms. Fantastic. Well, I think with that, Ree, thank you. Mark, thank you. Laura, I'm sure you're still there as well. Thank you all for some excellent talks this afternoon, and I think we'll draw the session to a close. Thanks very much.
Thank you, everyone. Thanks very much.